Welcome. Today, we're going to talk about a case of a patient who came to the emergency department presenting with chest pain, and we're going to ask ourselves some difficult questions about this patient's evaluation and management.
Susan, we got a chest pain here. Trauma 2's open.
Patient complained of mid-total chest pain, diaphoretic, vomited twice, sublingual nitro, 2 mg morphine. Says he's a doctor. Sir, are you... Oh my God. Dr. Casey.
Dr. Lewis.
You too.
So, our patient presented as a 50-year-old man with chest pain, substernal, by ambulance. The ambulance providers, or EMS providers, said that he vomited 2 times and that on examination they noticed that he was diaphoretic. And in the video you can see that he was pretty sweaty. They gave him some treatments in the pre-hospital arena in the ambulance, and they gave him nitrates and they gave him some narcotics. They gave him 2 milligrams of morphine, so a fairly low dose of a narcotic pain medicine. At this point, we're about to enter into this patient's room who's obviously in our sick category, and we want to evaluate, think, and act simultaneously. So we've got to think about what questions on history and what key findings on physical exam are we going to look for in these patients.
Run a 12 lead.
How's Steinman?
Tachy 120, risks 24.
Where are his blood results?
What's the EKG say?
So one of the early things we want to do is obtain an ECG, and here it is in our patient. So let's interpret this ECG. So what are the key findings on this EKG? Are there signs of ACS? Are there signs of dissection, pulmonary embolus, or other concerning causes?
ST elevation in the inferior leads.
I'm gonna die.
You are not going to die.
So in this one, once we've interpreted this ECG, we're going to summarize what's going on with our patient. We have a patient who has ongoing shock, as evidenced by his sweaty skin and cool, clammy skin. He has chest pain. He has an ECG, which was interpreted by our doctor as having an ST elevation myocardial infarction. At this point, we have to ask ourselves, what treatments should we administer, and what treatments would we want to avoid based on what we've found thus far, and why would we want to avoid specific treatments that we can use in some chest pain patients?
No cardiogenic shock. Okay, ET2 7.0.
More respiratory down. Open up the IV. Try to Lindbergh.
Bolus 1 milligram atropine IV.
Color code?
It's falling, Susan. 60/35. Start a dopamine trend.
So now our patient is decompensated. He's become unresponsive, meaning he's not able to talk or interact. The nurse was repeating his vital signs and noticed that he had bradycardia. They didn't say the exact rate, but we can assume that it's probably less than 50 beats per minute. His blood pressure was very low at this point, at 60/35. And our physician began by managing his airway and administering some fluids and some medications. So they ordered IV fluids, but they didn't order a specific amount of IV fluids. So what amount of IV fluids and how would we want to give this in our patient? They ordered atropine to decrease the vagal tone and hopefully stimulate the heart rate, and they ordered dopamine as a drip. Are there any other treatment modalities that we would consider in this patient other than the atropine, dopamine, and IV fluids.
Okay, 402 tubes in. Bag him.
All right, you may need a pacemaker.
Carotid's okay.
Yeah, let's get him upstairs now.
So in our patient, we have stabilized his airway, administered some fluids and some medications to increase his heart rate and improve his cardiac output, and they're dispositioning the patient out of the emergency department. And the question they have to ask themselves are, if they think this is a heart attack leading to cardiogenic shock, which method would they want to use to open the patient's coronary artery? And the two methods that we typically use are going to be either fibrinolysis, or we're going to use percutaneous coronary intervention, PCI, and angioplasty.